Good morning, everyone, and thank you, organizers, for giving this opportunity. I'll be talking in favor of high hip center. It's true, dysplastic hip, THR doing is a surgeon's nightmare, and which is evident in a title in a JBJS, hip pathologies that bedevil the dysplastic hip, not for a shallow surgeon. And the challenges are to bring down the hip center and get good cup coverage, initial fixation, and to get it reduced, need for subtrochanteric osteotomy, and to prevent sciatic nerve palsy. But all these challenges increases if you go for anatomic center. Now in Crowe type 3, the acetabulum is shallow and oval shaped, and if you go for anatomic hip center, then there is a poor coverage leading to unsatisfactory initial stability and low long-term survival rate because of this superior lateral bone defect. And this bone defect, if you go down, require most of the times structural bone graft. And these bone graft have their own problem in the literature. Even Harris, who advocated this later on, he himself described the complication of this superior lateral bone graft. If you go for high hip center, then there's an adequate bone coverage up to 70 to 8%. And that reduces additional surgery of bone grafting, shortened operation time, and simple procedure. In latest, this three-dimensional reconstruction technology papers, the high hip center can greatly increase the bone coverage of the cup, increase the initial stability of the cup, better bone growth, and long-term survival. So how high you can go? It depends on pelvic height and wherever you get maximum bone coverage. In American population, Harris described 28 millimeter from inter-teardrop line is acceptable, whereas Japanese, a short stature, 22 millimeter above inter-teardrop line is acceptable. High but not lateral is acceptable. High up to 30 millimeter, but not lateral more than 25 millimeter is acceptable. Does it causes more dislocation rate? Commonly, the anterior dislocation result of extensive combined anteversion and decreased femoral offset. So high hip center does not cause increased dislocation rate. Does it cause more polywear? No. The polywear in long-term survivorship, it has been comparable to same as anatomic position cup. Now, does it causes abductor strength and post-operative limp? Restoration of optimal femoral offset and abductor lever arm produce satisfactory result even in high hip center up to 30 millimeter. And this is all because of after this introduction of modular stem in 1995 onwards, the results are much better, which Girish mentioned 1998 paper. Before that, there was no modular stem like SROM, and results were definitely the poor. If you go for 10 to 15 years outcome, there's an excellent outcome in various literature in recent papers 2009, 12, and 14. In the paper which Girish mentioned about this 2001 CORR, there's no obvious difference could be observed in Harris hip score and revision rate, but definitely they said the dislocation was high, but there was less chances of sciatic nerve palsy. Girish picked up for his topic. Now, take home message based on my scientific literature and evidence, do not chase anatomic hip center, go for high hip center but smaller cup for maximum coverage and to save bone for future revision. High up to 30 millimeter is acceptable, but lateral is not acceptable more than 25 millimeter. Use modular stem for the correct vertical and horizontal offset and for the correct anteversion. Use 3D bone model for planning and practice to make the surgery easy. Thank you.